Okay, good morning, everyone. So, afternoon, everyone. Thanks so much for being here. And sorry for that short delay. I think there's another session, the food session that was still running over, so that's why we were slightly delayed. My name is Stanley. I'm a PhD fellow here at LSE, and it's my pleasure to welcome you all here to this session on diaspora communities and the COVID-19 pandemic. Okay, so why diaspora communities? Well, we all think back to the time of the pandemic, which I'm sure we've been doing throughout today's discussions. There was, in public discourse, there was something of a spotlight shined on so-called ethnic minority communities in the UK. And the tone of this varied. At times, we kind of had the tone of the discussion of some kind of humanitarian crisis. Why are casualties so high? What's going on? What's going on at Royal London Hospital? This sort of disaster coverage. At times, there was a kind of more or less subtle accusatory tone in the air, and notably one Conservative MP went on a well-known radio station and explicitly blamed so-called BME communities for the high rates of infections, so-called Muslim communities, saying that certain communities were not taking the rules seriously. Now, there's a lot that might be said about both of these kind of tenets of discussion. But one of the striking features from, I guess, our point of view as social scientists is the fact that the discussion was often about this so-called BAME community, BME community, BAME standing for, as we all know, Black, Asian, and minority ethnic. Now, there's a certain history to this term in the UK. Some might see it as the kind of inheritor of the concept of political blackness in the 1970s. But for a lot of us who may be in some way were closer to the ground, whether through friends, family, the work we were doing, there are some serious questions about whether this term obscures more than it reveals, or what might be the advantages of it from a political point of view, but what might it obscure from a sociological or a public health point of view. So in this session, we decided to take a slightly different angle, and rather than talking about the particular ethnic minority communities, namely the kind of crude box that people are invited to tick when they fill out a form, we're talking rather about diaspora communities. That is about communities which have a certain shared history, a certain shared migratory trajectory, a certain shared orientation to a place or a set of places, a place of origin or a place of arrival. Not to homogenize and not to claim that everyone within a so-called diaspora community will have the same experience, but there are some commonalities in social experience there which may be useful if we're thinking as we are today about social infrastructures and social relationships and how they might invite us to think differently about the experience and response to something like a COVID-19 pandemic. So we thought that would be a useful lens to explore, and we brought together a fantastic selection of researchers and other activists working with and within different diaspora communities in the UK. Quickly, we have Dr. Kaveri Qureshi from the University of Edinburgh. He's got a long experience working with South Asian communities. We have Professor Joanna Lewis from the LSE, who's been doing some really fascinating research in collaboration with the Somali community in London. We have, in absentia, Grace Romero, who's an organizer with the Latin American community in Southeast London. Unfortunately, Grace, who's a colleague of mine, we had a very sad bereavement of a close friend and colleague last week, so she can't make it. But I'm going to read a short statement in her absence. And then we also had somewhere, although he's not quite here yet, maybe he'll arrive, Moses Mulimira, who's a project manager with the NHS Global Health Fellowship and has done a lot of work with the Ugandan community in the UK around mental health. So we're going to have a chance, panelists are going to have a chance to share their findings from their research, their experience, and then we'll have a chance to discuss it together. And before we launch into that, we probably haven't got time for everyone in the room to introduce ourselves, but it would be cool to have a sense of where we're coming from, the different sectors we're coming from. So maybe if you are here, work in a university or a student, could you maybe raise your hand? Okay. If you work in local government, maybe raise your hand. In a charity or community organization?
Kind of.
Yeah, NHS? Okay, so we've got a sort of spread of academia researchers and then
Higher education, no, secondary education.
secondary
That's
education
not
as well.
what
Fantastic.
Yeah.
All right, that's brilliant. Okay, so we're looking forward to discussing and all sharing our insights. So without any further ado, I'm going to introduce our first panelist. Dr. Kaveri Qureshi is a senior lecturer at the Global Health Policy Unit within Social Policy at the School of Social and Political Science at the University of Edinburgh. She's also at the Centre for Research on Families and Relationships, where she's the co-director. Kaveri's work is threaded by a concern with intersectional inequalities and how gender, race and ethnicity, class, caste and religion shape experiences of health and intimate personal life. So over to you, Kaveri.
Thank you very much. I came from Edinburgh this morning, so I haven't had a huge amount of sleep. So I'll try to make this, I'll try not to read from my thingy, but how do I get the, is it on? Is there anybody joining from Zoom? No. But anyway, I'll show the website at the end of my slide. But it's not showing the slide. Yeah, so this presentation draws from a research project. It's a health experience study of COVID infection and recovery in the UK. And I'll try and speak a little bit around the points that Professor Laura Bear was making earlier on about the ways in which inequalities have been reproduced through government policies and its knowledge practices, creating long-term structural inequalities, and thinking about which forms of pandemic governance intensify inequalities and which reduce them. And it sounds like much of the work that this commission has been undertaking has been with policy mediators, but there was a lot of talk this morning about giving weight to evidence from those most affected. And so that this presentation is sort of in keeping with that, looking at policy subjects, if you like, people who are directly targeted by policy. And specifically, I'm going to be looking at public health communications during the pandemic from the vantage point of people of South Asian heritage, South Asian diasporas in the UK. Much of which fits in for those who are in the Trust Lab earlier on with this discussion we've just been having about trust in public authorities and how those who were not able to trust in the public health communications for whatever reason become stigmatized. So a little bit of context, this was an interviews-based study, like much anthropological work during the pandemic online interviews, which mostly took place in 2021 by myself, Tanvi Rai and Anna Dowrick, who are in Oxford. And the study was looking across, we were trying to understand the whole spectrum of experiences of COVID infection and recovery in the UK. So we did interviews with people who experienced it like a mild cold, all the way through to people who nearly died in ICU. And those were incredibly humbling and hard-hitting interviews, as well as the spectrum of kind of COVID experience. We were also interested in the ways in which people's social positioning, specifically around diasporic heritage, social class, age, generation, all of this sort of comes together to shape people's experience of COVID. So again, as I say, it was a bigger study with 70 participants who took part in it. It was also, as well as a research study, intended to generate a sort of public facing resource, which I'll show you at the end if I can somehow figure out how to get out of the PowerPoint and show you an actual website. Yeah, in keeping with this like focus on diasporic processes, I'm going to think about South Asian histories of migration and settlement and how those fold into pandemic experience, as well as attending to diasporic forms as kind of products of everyday realities in which diasporic groups live and interact with other social groups and specifically become subjected to processes of racialization and racism. So as I say, the focus today is, given the focus on pandemic governance, is on the public health communications. And we were talking in the Trust Lab just now about how sort of being pitched back into that experience of the pandemic and the lockdowns brings back a lot of memories of like extreme anger surrounding the response that you can see unfolding around you. And so I'll just take you back just so you can relive all that anger through some of the public health communications that we're talking about, relying on a backdrop of other academic research around these communications, which is much more textual, looking at the images and the soundtracks and the affect and emotions that it's intended to create, predominantly emotions of fear, and as an overall ethic of kind of individual responsibility for contributing to and responding to this pandemic. And that's particularly important in the UK context, because like in other countries where it went completely out of control, like the US, the whole strategy is about getting individual citizens to manage their behaviour rather than other, settings like Australia or Taiwan, where it was much more to do with an external threat and border controls and PPE and so on. So the citizens themselves become the threat, and the citizens' behaviour becomes the key pivot to change the way that the pandemic would play out in the UK. So here are some of the images. We've got sort of academic analyses of the different phases of the public health communications response. First of all, setting the scene in terms of creating this sense of individualised responsibility, ticks for yes, red for crosses, and then a phase of management of risk as we went into the summer, and businesses like bookshops here start to be opened up, mitigating the risk again as we sort of focus in the autumn of 2020 on sort of trying to figure out how to negotiate the opening of the economy with pandemic controls. And then finally, in the second wave, this very famous and highly problematic campaign that you probably all remember, the Look Them in the Eyes campaign, which really sort of triggers in these sort of wider effects of individual responsibilization, blame for those who are transmitting COVID, and really sort of pinning the transmission on those who are non-compliant. As again, here's another image from that Look Them in the Eyes campaign, and as well as sort of prominent use of racialized imagery within these campaigns. So this is the kind of broad backdrop in terms of just reminding you about the public health communications that were taking place at the time. Those are the academic papers which critique all of this. And our study really sort of speaks from a different perspective, not a textual analysis of a textual critique of these campaigns, but an analysis of reception. What did people make of all of this? Did they notice it? How did it impact upon them? What feelings did it leave them with? And that's where our interviews come into it. And specifically from the perspective of like South Asian diaspora in the UK. So the first way I want to think about diasporic processes is through, like Isaac was saying, thinking about sort of histories of migration and settlement and sort of trajectories, which are also bound up in people's economic positioning. So we were looking specifically in this paper around the experiences of people of Pakistani and Bangladeshi heritage, who, as Laura was talking about in the panel earlier on, faced the brunt of racial inequalities in COVID mortality in that deadly second wave. And a lot of this is to do, as she was intimating, with the sort of structural production of COVID risk of exposure and transmission, to do with the particular industries that people are working in. Pakistani migration in the Pennine Belt, the textile belt, which was decimated during the late 1970s, 1980s. There's a very famous book called From Textile Mills to Taxi Ranks, and talking about the widespread sort of shift from manual production, manual labour in manufacturing industry to service industry and low paid work through the taxis. And, 4 out of 10 Pakistani adult men in the UK work in taxis. So this is the sort of context that we're thinking about in terms of the reception of this public health communication. So I got 3 themes to talk around, and more or less 3 or 4 people to illustrate this with. So we've got a concentration in particular sectors, and particularly in sort of essential work, which continued during the pandemic. So Samira, whose husband was an Uber driver, was able to keep working during the lockdowns because transport was an essential sector, but they had no income coming from it. And she says taxis were absolutely essential, so they were allowed to continue to work, but it was absolutely dead no one was taking any taxis anywhere at all during the day or not. So me and my husband, he'd be working right through the nights and mornings, just everything crazy, trying to get a couple of customers in. Mudassar, a taxi driver, another taxi driver, explicitly raised the NHS England public health messaging around stay at home, complaining that my sisters, everyone keeps phoning me, this is whilst he's sick, finding out how I'm doing every day. And I'm telling them I'm still sick, blah, blah, blah. So they was telling me, we told you, don't go to work, just stay at home. But at the same time, you've got to work, you've got to pay your bills. The government is saying, stay home. Okay, I said, I'd rather stay home. It's no problem. But I got so many bills to pay. I got my rent to pay. Who's going to cover my cost? It's not easy to stay at home. Unless you're financially well off, you can't stay at home. And this kind of contradiction between being set up to protect others, but not being protected by the sort of umbrella safety net of the state was experienced with even greater intensity for those who were care workers like Mohammed and Shireen, whose comments also take us onto this second theme to draw out around the racialization, the representation of racialized COVID risks in public discourse. So Mohammed saying the portrayal of COVID risk among people of colour was exaggerated. They're not telling the whole picture. They're just blaming the BME people. But COVID doesn't choose who is going to catch the disease. And his wife Shireen chipping in, it's for everybody. You can get it, anybody. It's not like BAME, exactly like you're saying, Isaac. Yeah, Shireen continued to reflect on the consequences of the racialized imagery using the public health communications, talking about racial segregation in British society and how the media feed into wider existing notions of sort of othering thing. They're saying we are the poison, we are sick, we are very affected, we are the ones who's going to spread the germs around. That's how the media and the public are portraying the community. And if you live in a community where you don't know any BAME people, then that's what you're going to think, isn't it? So the third and final theme, very quickly, is around how people responded in quite diverse ways to these sort of blaming narratives. So one strategy that we find in interviews is to sort of accept the premise of responsibilized individual responsibility, but then to distance yourself from that personally in a kind of bad people exist out there, but I'm not one of them sort of way. So Fahmida, British Bangladeshi community worker whose husband, like many Bangladeshi men, worked in a restaurant sector, she invokes and seemingly accepts this idea of personal responsibility in relation to social distancing, but then refutes the criticisms leveled at British Asians in mainstream British discourse, what you were talking about. Some communities not. What was the quote from the Tory MP you said? Some communities not taking it seriously. Not taking it seriously, yeah. So she says, people say, oh, Asian people, they're always going in and out of their friends' houses and their brothers and sisters' houses, but they're not. I think in my area, it's been nearly 6 or 7 months my friends are not coming to my house. We're not going to their house. We just sit outside to talk to one another because we're very careful. We just go for shopping in Tesco, grocery shopping, nothing else. We're very careful. So that's one way of responding to this kind of responsibilization messages. And then another is to go even further and offer a kind of alternative narrative, which is instead foregrounding the government's responsibilities as a pandemic actor. So this is Shaista, a local authority worker, who says, I think it's shocking that the government is trying to absolve responsibility for taking control of that pandemic and is busy telling people that actually your behaviours are on you. The whole ethos of that messaging is to blame people individually for a pandemic rather than taking responsibility for a well-messaged, clearly defined public health strategy that's going to save lives. So I'll finish here, but just sort of some lessons, obviously, about public health communications. We presented some of the findings with people from NHS England, and the senior programme manager got really interested in the materials, sort of part of their project for doing what you call culturally competent communications training, which is clearly like a very needed and important initiative. But obviously beyond cultural competency in communications, I think we need to go back to the kind of recommendations that Laura was outlining earlier in relation to public authority and trust around ensuring that protection is given to those who are unable to follow the recommendations, and sort of the extent of economic and social support being provided to vulnerable people. So that's it. Yeah, thanks. And there is a website. Oh, yeah. If I can get onto it. Oh, I stopped that sharing maybe. Am I going to go, will it show? No. Anyway, I'll try and share at a
I don't know
later
why
stage.
it's not opening.
Yeah, it's not opening. Can we get it from Explorer, MS Explorer? Will that load? I'll find it. You're not using a PowerPoint, are you? So I can show it in the background.
That's cool, it's going.
Thank you.
PowerPoint, written notes.
There we go. So this is the public facing resource that we've got, which is, so it's got sort of verbatim excerpts, videos and audio excerpts, as well as textual excerpts from people's experiences of COVID. And it's sort of curated so you can navigate all the different sort of aspects of people's COVID experience that we were able to capture. So this one, sources of information about COVID, this has got quite a lot around people's feelings about the public health messaging. So it's called Health Talk, and if you just look around COVID, you'll find a wealth of resources to explore if you're interested, or if this might help you in your work. Thank you.
Brilliant. Okay, so now over to our next speaker. So Professor Joanna Lewis is an international history professor at the London School of Economics and Political Science. She completed her master's in the history faculty at the University of Cambridge, focused her doctoral research on colonial Kenya. She's the author of The Women of the Somali Diaspora, Refugees, Resilience, and Rebuilding After Conflict, many other publications. Today, she's going to be focusing on her collaborative research with the Somali community in London.
Thank you so much, Isaac. Hello, everybody. I'm going to present my findings of the findings of a micro study on one Somali community in the East End of London. And this was research carried out with Dr. Firoz, one of the only Somali GPs in this part of London. I would have loved that Farah could be presenting the research today, but guess what? She's a busy GP and she can't be here today, but I think she is trying to listen online, and she's been texting me a few things now. So we had a fantastic opportunity to get up close and personal, to get a snapshot view of what unfolded in the first wave of the pandemic, thanks to Farah being a Somali GP, because we were interested in what happened between March and September 2020. We wanted to generate some data. We wanted to record individual experiences. We wanted to examine the reasons behind these high rates, which weren't coming through in the media, and to suggest ways of moving forward. And you will remember, I'm sure, that it became quickly apparent by April 2020 that there was something very dramatic happening to the Somali community. And there were Somali victims of that first wave of the pandemic were amongst the first to present clear evidence of a massive disparity on ethnic lines. And although that was picked up, and we have this report from Public Health England in June 2020, COVID and ethnic disparities, I just want to draw your attention to what they wrote about Somalia. It is an area in Western Central Africa. Now, my geography isn't very good, and if you travel with me, you will not hear you have arrived at your destination. But even by my standards, you know, that is pretty shocking. What does that tell us? So what we had then was we had qualitative analysis of patient data that Farah had permission to analyse, records at the surgery where there were proportionately a high number of Somali families registered there. We also did qualitative interviews, and we were very fortunate that we got the opportunity to do a training course for NHS North East London CCG training hub. And so we had feedback from that training session that we did, in which we presented some of our findings and some of the recommendations that we wanted to make. So I'm only going to talk in the first bit about our findings, according to my instructions, great instructions from Isaac. So I'm going to talk about this in relation to three headings. What was actually happening? What did we find was happening from our results? What did the detailed data that went with patient records. What did that reveal about those high level of fatalities and a high propensity for high levels of infection? And thirdly, I'll just talk briefly about this controversial area of cultural factors. So very briefly then from the figures, from the clinical audit that we did, the hospitalisation ratio of Somali patients registered at the GP practice that came forward and presented symptoms, the hospitalisation rate was 12.9%, which is high. Death rate, 5.5%. And I'm saying these figures in a cold, dispassionate way, but for those figures, they mean actual lost lives and still being grieved. Around those figures then, it's important to stress, these are also moments, figures that came with panic, horror, anxiety and stress. There was awareness, some of our interviewee said that Somali children were catching it when in the news it was said children couldn't get COVID. But one of the first child deaths from COVID was a young Somali boy aged 13. We were given insights, for example, people just withered. That was what one interview said. Families got wiped out. One community leader said that in mid-April, at one point, there were 5 deaths a day of people she knew. And why it was particularly traumatic is that if you add in the dramatic exit arrival stories of a refugee community, or the East End Somali community, of course, it's very diverse, it's very old, so it has 3-4 generations. But it also has refugees from the 1990s, the end of the Cold War, who've come to the UK in a situation of high stress. And this is one quote: "We have already lost everything once. This cannot be happening again." Well, the second major findings from our Somali patient records then were to do with what was going on behind these high statistics, these high level statistics in our case study then. What was behind prolonged COVID-19 vulnerability and this high level of risk of death? So we found there were a number of interrelated factors from our patient records. First of all, many who exhibited what I've been talking about there were suffering from long-term comorbidities. In other words, many of those patients that sadly died had multiple underlying health conditions. But the important point to stress, and it's again thanks to Firoz who can give this extra interpretation for us, is that the health conditions are associated with communities that have compromised self-care and stress-related conditions. So these include diabetes, a whole spectrum of gastric problems, hypertension, depression, those are the areas. One interviewee said, Somalis caught COVID in a different way because Somalis are always tired. We never stop. Secondly, there was also a correlation with high density living. Again, many of the patients who sadly passed away all exhibited COVID and went through it in a very extreme way. They were, we knew from the records, we could see from the records, sometimes on average, rather, there were 10 people living in a flat with 3 bedrooms. The living room was often permanently turned into a bedroom. 5 or 6 people perhaps sharing 3 rooms was another common example. So what did that mean? Well, that meant, how could you self-isolate? What happens also when you only have 1 phone in that household? You have multi-generational occupations. As I said, this is a community that goes back 3 or 4 generations, that takes care of its elderly within the family often. So if you add to the statistic that 1/3 of single wage earners were in the front line, and then you also impose on that a 1/4 are clinically vulnerable, you can see where I'm heading with this. As many said, we go it alone. We only have each other. Another factor that made a significant issue with regard to our pattern of high level of COVID deaths was also occupations, that these victims and their families were Uber drivers, as we've heard, hospital porters. They were working in the retail sector where they could not work. They were bus drivers and they were not given protective clothing. Many of these families had rent to pay, so the single earner could not afford not to work, or they were working in the care sector. And so, as some women said, many of our men brought the virus home, but that was because of occupational factors. So in addition to those then, I also want to bring in another aspect to our criteria, and that is the relationship of just being elderly. Many of our victims were isolated in their own homes, or they were living in those multi-generational houses where young people or the breadwinners brought the virus home. Many couldn't understand, didn't have access to IT facilities to get the messaging, and many simply perished. And there were many sad cases of families who knew elderly who just perished at home. They were used to having family interpret for them, and then when that option was closed down because of a culturally insensitive approach, they were lost. They were simply lost, and many perished. But the final point, however, is also racism within the delivery of NHS services, in that there was already a lack of trust and a huge anxiety about accessing NHS services. That was particularly pronounced with regard to even going into hospital. And then when you had the stories coming through that there were people just lying on the floor, dying in hospital, and also that people were not having a proper Islamic burial, then that escalated that reluctance to go forward and deal with hospital. But it wasn't just hospitals, it was also the general practice, that actually there was anxiety around conversations with, say, that your healthcare navigator on the telephone, if you only have one telephone, and then you're trying to get through, but you don't understand what's being said. So there was a huge issue, sort of our fifth point, if you like, of structural barriers to accessing the COVID advice, the COVID treatment. Some of the community organisations, for example, didn't know when there was a test centre opened up about 200 yards from the community, where the community hub had been giving out information, functioning as a kind of pop-up NHS GP, if you like, but then weren't even brought into the loop when there was a test service literally 100 yards behind. So finally then, what about, just lost my notes here, what about culture? I mean, that's a controversial issue, and we certainly did have evidence where women in particular were saying, yeah, there was a number of big parties in that week before lockdown. I don't remember if that week before lockdown, where we all did things that we probably shouldn't have done, but we wanted to make the most of it before we had lockdown. Also, traditionally, when you have a family bereavement, families, communities congregate together. It's a form of healing, it's grief, it's paying respect. So that happened for a while, and there was also some talk of shishi bars being open and people not taking lockdown seriously. However, if you look at cultural factors in balance, and you add a second cultural factor, and that is the existence of established community centres that were run by Somalis for Somalis, and that were very well known within the community, acted immediately as food banks, acted immediately as passing on information, also passing information back to Somaliland or Somalia. So community organisations actually fill that gap. So if you want to talk about cultural factors, then you need to talk about that second point, I think, which we felt outdid, the first point with regard to cultural factors. There were also new community organisations being established as well to distribute food messages, support the community. So that activism and that history of having to, be there was very much important. So I think it's really the third point I would mention on culture is a long established culture of neglect, and that the Somali community in particular, because it is seen as being a victim of hyper invisibility, ironically, because it's so visible, but it gets tagged with so much negativity from knife crime, Islamophobia, racism, a lack of understanding about the diaspora's complex and long history within the fabric of British society, British politics, British culture. I could go on. It is that culture of neglect, discrimination overall that is the most important factor in explaining what happened. And one of our healthcare participants in our training session said, yeah, we've been talking for 20 years about the need to get data about the Somali community. Well, this was one of the consequences, wasn't it? It wasn't just neglect, it was an absolute tragedy as a result. Thank you.
Thank you, Joanna, for that very powerful presentation. So our third analyst, Grace Romero, for those who were here at the beginning, she asked me, last week she experienced a major bereavement, and she asked me to read out something on her behalf. And as a former colleague, I couldn't say no. But I'll try and be quick, because it's obviously less interesting hearing it from me than from Grace. Hello, my name is Grace Romero. I'm from Ecuador, and I'm a community organizer for PACT, Parents and Communities Together project in South London. Citizens UK established PACT, a community-led social support project to support and empower parents in order to improve the well-being, development outcomes for young children in Woolworth and Camberwell. The project adopts a community organizing approach to promote early years development, combat isolation, support physical and mental health, especially maternal mental health, and remove any barriers that prevent families from accessing health and social services. We offer a variety of weekly groups to provide a safe environment for parents to build a network of support and share their experiences, while also providing a fun space for kids to play. Espacio Mama is a weekly Spanish language support group for parents of babies and toddlers. They have a special time each week for parents to discuss relevant issues and challenges. There was a need for Latin American parents to gather and discuss issues that affected them in their own language. My work involves developing relationships with parents in order to boost their confidence and providing safe spaces for them to speak out about injustices in the community, empower, train, and develop parents leaders so they can realize their own abilities to lead change on issues that are important to them. Connecting my community on Citizens UK campaigns for better change and building power is an effective way to be more visible in the local area. So during the pandemic, Espacio Mama moved their regular sessions online in March 2020. In addition, we committed to listening to our families through a community audit to examine the effects of the lockdown on mothers and highlight the most significant challenges encountered during the lockdown. During the same year, we worked with the Indo-American Refugee Migrant Organization, IRMO, to conduct a study of the impact of COVID-19 on the lives of Latin American migrants. The study highlights the community's disproportionate receiving of impact and vulnerability, including those living in poverty and those experiencing precarity, both in their employment and living situations. In Espacio Mama, we found out from 100 most vulnerable parents that 39% worried about their children, i.e. how to occupy and entertain their children, how to deal with the challenge of schoolwork and the risk of children contracting COVID-19. 37% had concerns about basic needs not being met, such as not being able to afford food, rent, problems with debt or benefits, job loss, immigration status related work concerns, and housing issues that were affected due to the pandemic. 34% had anxieties around the management of COVID-19, i.e. isolation they felt from their friends, communities, family members outside of their household and having to stay indoors. And 80% had barriers to engagement as a result of language barriers. Mothers attending Espacio Mama were particularly vulnerable, with a third of the parents not at all confident using English and only 4% very confident in English. As a result of these language barriers, parents struggled to navigate online, the moving of activities online, and support their children with online learning in school, which all children had to do. A third of mothers didn't have enough internet devices to meet their needs, with only a quarter having their mobile phones to access internet. Lack of devices on internet are largely explained by financial problems. Limited devices often mean that they're being shared between family members, recalling what Joanna said, compromising children's education as well as entertainment and ability to unwind during this difficult time. Now, the IRMO study found, similarly, half of low-paid Latin Americans in London were out of work during the pandemic. Half were experiencing financial hardship, including 35% receiving no income at all. 3 out of 10 were experiencing food insecurity. 62% of Latin Americans in insecure housing situations, 58% struggling to pay their rent, and some had already been evicted in spite of an eviction ban. And a bit of contextual information for those who don't know, but Latin American community in London is very heavily concentrated in private sector housing, not so much in many don't have access to council housing. 1 out of 7 were not registered with a GP. Many are struggling with mental health issues. Latin Americans had limited access to the furlough scheme, and 27% were not entitled to benefits. So lockdown was a difficult time for most Latin American families living in the UK, because they have the added burden of sending money to relatives back home, because most Latin American countries did not have government support, leaving many relatives without jobs, pushing many people further into poverty. There were stories also about families losing loved ones back home, which led to more Latin American families here becoming in debt to support their families with hospital treatment and funeral services back home. As an Ecuadorian, with my own testimony, I was forced to send monthly payments to my family back home after my parents and brothers both lost their jobs. So in summary, my community is still on its way to being recognized, as there are some challenges in remaining largely invisible in terms of policy, strategy, and access to mainstream support, which combined with COVID exacerbates the challenges already faced by many Latin Americans in the UK. So a very challenging picture, and some themes, I think, which resonate across the 3 different communities under discussion. It will be brilliant now to open up to a wider discussion. We have 20 minutes. Does anyone here have any thoughts, questions, responses? Yes, sir.
Do you want to do ladies first?
Sorry, I thought I saw your hand first.
You said
Maybe,
you had
sorry, maybe
Oh,
when we're speaking, we could just introduce ourselves, our name, where we're from, organisation, and so on.
Okay, my name's Des Blake. But a great morning actually, going to different breakouts and different meetings. This one was particularly interesting to me. I was going to ask you, you had another someone who's going to present. What subject was he going to cover?
He was going to cover the experiences of the Ugandan community in the UK.
Oh, right, and he's not going to turn up.
He seems not to be here.
Okay, that's all it was. I just wanted to find out.
Yeah, but hopefully we can put him in touch with people. Maybe he had a presentation he would like to share. I don't know. Yeah, he would be happy. I'm sure he'd be happy to share what he was going to present.
Okay, so I've got to say that I'm from Newham COVID champions. So after the break, there's another meeting.
Are you presenting in that day?
I may be contributing.
That's it. Whereabouts in Newham?
I live in Plaster.
All right. From Manor Park, sorry.
Right, super.
All right. Okay. Adeline?
So yeah, thank you so much for your very fascinating presentations to you both. I just had a question. I was wondering if you had any data about the effect of the stigmatization of minorities during the pandemic. In particular, I wondered if you knew whether it had changed their relationship with the state, this stigmatization, and if so, in which ways, and whether also it had changed their definition of themselves as citizens. And I don't know if you had any information about whether it has modified the voting patterns. I don't know, it's probably outside the remit of your research questions.
I don't have any data on voting patterns, but I mean, this theme of, that's something that we are concerned with and understanding. I mean, at the moment, we have a huge corpus of like 73-hour interviews to work through, and so we're sort of looking at this with specific angles around people's reception of the public health communications around people's reception of vaccination campaigns and sort of working at it bit by bit. So there are different aspects to what you're saying that come out in relation to all of those cases. But this, I don't know if this, if I can tack this on, but I was actually really arrested by one of the quotes that you offered, Joanna, about how we go it alone and we only have each other, and how that sort of resonated with some of the discussions in the Trust Lab earlier, about this sort of sense of not being able to rely upon the state, and something which I'm very interested in terms of how the pandemic sort of played out in really unequal ways and changed people's relationship with the state, is that there was a whole cluster of interviews we did with people coming from positions of privilege, racial and class privilege, who talked about how, you know, when they themselves got COVID and they didn't know what to do, and they called the helpline, and they realised that you just get onto the helpline of NHS 24 and you just get looped between different voicemails and different things. They felt this sense of abandonment, and it was like, for them, it was like something that they'd taken for granted all their lives as a sort of underlying security about their lives, that, you know, there is this government out there, this sort of biopolitical underpinning, like supporting us and protecting us, and actually when you scratch, it's not there. And then there was interviews with other people who'd never expected that to be there in the first place, and actually were kind of building resources around themselves outside of the ambit of the state, through communities and even through transnational communities and connections, not trusting the NHS and rather waiting to go back to another country to get your health MOT from a service that they know better, even if that's a private service. But to do so, I don't know, but your question asked, it's a really complex question, it's a really dense question, and you can approach it from lots of different angles in relation to different aspects of the COVID response. But yeah, I think what you're pointing at in terms of the ways in which the response has alienated and sort of created a recoil is a really powerful insight. Yeah, I don't know.
I think the East End community shows different responses, because what I've mapped out here is very traumatic, and so there has been, I think, a shutting down of sort of people in shock, families still in shock. However, on the upside, the positive side, is the anger, the sense of outrage and what they went through, and this can never happen again. This has mobilised, galvanised community organisations. Think of Coffee Afrique, for example. There is a confidence. And the experience of COVID was that they were experts in experience, and they could pass on what was going on. They shared with each other, and they made a difference. So that has translated into, I think, micro pilot projects by community organisations, where they have proven themselves now with gathering data at their networks, sharing information, and particularly being vanguards in the role of mental health and community sensitive approaches to mental health, which then they can share. So that expertise is now being acknowledged, and they are being brought in partnerships in local government initiatives on health. So with Black Lives Matter and the experience of the pandemic, there's much more confidence and assertion in going to local council meetings and, you know, representing themselves, because they understood, you know, what they had known, and now they have more data and a much more of a moral sense of, you know, we've got to start putting this right. So there's lots of positives, if I can say that.
Can I just, I'd love to hear a bit from the experience. Look, people in the room have got so much experience around this and how it resonates. But just on that coda, on that sort of stigma, Laura Baer this morning, who talked, she really put this on the agenda in the SPI-B meetings. A kind of, there's the way that people talk about stigma in relation to COVID and public health is like, oh, someone's got COVID, you know, don't go near them or something. But she was really important in putting in those meetings with government the sort of structural stigmas on the radar and trying to get engagement around that. So yeah, it was. Yeah.
So just want to say again, it's been quite a privilege to be here this morning. Really powerful, and the thing that's standing out to me a lot in this whole COVID. I'll show I'm Lloyd Walker. I'm from Tower Hamlets, and I'm a carer and a VRA expert of sorts. But what I've realised this morning is there's all these communities that were not spoken to, not touched, and that's like I take for granted I have a mobile phone, but some of the conversations you had this morning were people in these communities that don't have mobile phones, that don't have the access to the internet. So, and these people, it seems like they were just left behind, and that's painful to hear, but it's also good to hear because I'm thinking, okay, this can't happen again, but something of a major standpoint can happen again. But it's just to get that communication across. The trust was a huge thing, and I had loads of arguments within the Black community. My wife is Latino, so it's kind of, when I'm hearing some of them stats, I'm like, oh my gosh, there are people that just never were just left, and that's really sad to hear that. But then the upside is, okay, so how do we then communicate this going forward? And like I heard about the Romanian people this morning, the Roma gypsies, to hear all these communities, and the way I flipped it was like, okay, we have technology. So we have short films, okay, people's attention spans a lot shorter. Then the whole world needs to know about these other communities that were kind of left out, or even London as a whole should know about these communities that weren't looked upon, and show what they went through, show their experiences. Because I think that this whole thing is now brought it back up today, and brought a lot of emotion, but we kind of brushed it under the carpet. Like, everyone's back to normal now, no one's really wearing masks. It's kind of, COVID is not even in the news, the numbers anymore. Every day it was 25,000 and we've dropped below this number. And I'm like, well, that's just on people that have tech. People that didn't have the tech, we're not even in those communities, we didn't even know. So I thought that short films would be a perfect way to show people this actually happened in your city while you were in, maybe it's not the comfort or safety of your own home, but there were other people that were not safe, in damp conditions, falling. So I'm just like, how do we get this message out? Like people's COVID experiences from these communities, and get those out there so people can see it. So younger generation go, oh my God, I didn't know this happened within my community. Then you have a contact with an older person who doesn't have a phone. So then you can, I don't know, filter it through there, and key people in the community, they need to be told it. So then to get into the community, because as a Black person, the 5G telephone mast conspiracy theory that sprung up right in the very beginning, I feel stopped the whole of my community just going and getting the jab. Like it was crazy. I was having an argument with my parents. So today, to hear this and to see this, I'd love it to be able to be taken into communities and shown, okay, there are people looking at this, and yeah, you were maybe left behind, but we're going to drag you kicking and screaming into the future. So that's what I'll kind of get in from today. But it's been really, really, really interesting. All that, I didn't know all this was going on. So it's good to know what's going on coming from the community that I live in. So thank you very much.
Thank you. Tech's a complex part of the story, right? Because on the one hand, there's all this potential that you talk about. On the other hand, a lot of these 5G rumors and all the rest of it, they were circulating on WhatsApp.
Yeah.
We all have, right? Well, many of us have friends, family, whatever, who receive this and were terrified, and to this day don't have the jab. So it's kind of a complex thing to understand. Elisa.
Yes, thank you very much. I'm Elisa from the Lalji Institute for Africa, and thank you for your presentation. I just want to emphasize some of the issues that John has talked about the diaspora, but also about Anchor. In 2021, I was affected by this, forced lockdown. And also when you talk about diaspora communities, maybe there are some that are settled. I think even the ones that are not settled were also disproportionately affected by the systems of these forced enforcement. And when you talk about Anchor, and maybe some few months you hear that maybe the minister will say, like, how many are we locked? Then you get more angry, because then it was a policy that was affecting. Of course, it was affecting everybody else who had left the country. But then, if you stayed here and you wanted to connect to your family, you are treated like a prisoner of war. But then also talking about Anchor, when I was very angry about it, I discovered that most of the security that were, in charge of those hotels were from Somalia. And I remember when I was feeling so bad that you have got to ask somebody for permission to go out and, enjoy the sunshine. He told me, oh, you come from Kenya, my wife is also coming tonight. And so you feel like, they are more exposed than you. And the government has put them there because, of course, because of the situation and all that. So, and then one of the other things that I also noticed is also the fact that there were also many of them sharing like one room, like when I was in a very big, shiny, room on my own. Some of the rooms, one single room was hosting like, 5-6 people with children. So, so then one of the issues that has been in my mind is also where is the space for solidarity also, because we felt like everybody felt like we need to be protected. And this discourse of these, ethnic minority groups that are problems to us also need to be contained in one way or another. So, so that feeling that we need to be protected from these people who are breaking the rules, also I feel closed also the space for solidarity, because I feel, tried class action, tried a few things, and we talk about what do we do with the minority groups going forward, then we also need to look inside ourselves and also maybe go back to issues of trust, while we taking care of each other. If some people only had each other for themselves, then where were the rest of us? And I think that is some space that has to be kept active also for those who are affected and those who are not affected, but also the way we also looked at the other. Can we have these conversations going on?
Opens up some questions about these studies are helping us to kind of look back and understand what happened, but what do they suggest for going forward? What do they suggest about kind of ongoing ways that communities interact with health authorities, the ongoing ways that crises like these are managed?
That's a good point. I just wanted to add something very briefly, because with the East End, for example, in Tower Hamlets, these are majority minority community areas. So building up empathy and understanding between those communities is highly important. Many Somalis felt that there were other ethnic minority communities that had a greater representation as nurses, healthcare workers. And so that was another issue of trust. That they felt they couldn't understand what people were saying to them, because the English wasn't very good. They sounded almost a bit like my father saying NHS is full of foreigners. It was almost that sort of scenario. And there is a big problem with the lack then of Somali GPs. And going back to your point, it would be great, Firoz trying to make videos in the Somali language about some of the core health problems that we know the Somali community is affected by. That data is there. And so to make them, to prefix that with a film about what they went through, that would probably make people listen more, get the younger community there. So I'll definitely be passing on your suggestion. Thanks.
Thank you. That's cool.
I think that was yeah.
Thank you. Hi, I am Melis. Thank you very much for sharing your fantastic work. My question is that perhaps if you have gathered some insights about how the impact of transnational networks, as you say also in the description of the panel. So obviously these communities are also connected to their country of origin, and also they are members of global diaspora, for example, Somalis. So was, in any way, were these transnational networks important, either like shaping people's perspectives or like lived experiences?
That's a good question.
Yeah. So I mean, Grace's presentation was talking about the burden of remittance sending and how that packed into her experience.
Yeah, and myself, I was in East London throughout the pandemic, and what I observed with friends of, I guess, the children of migrants from different diasporas is, I guess, one major way in which this structured things was the way this affected movement between kind of the place of origin and London, because this is something, some communities is something which is quite an important part of life, the ability to go back and forward, and obviously having to navigate all these complex border regimes and rules that that was one aspect of life that was complicated. I think that in some cases, some of the discourses that Charles mentioned, you know, these also travel. If you take, for example, the president of the Democratic Republic of Congo refused to get the vaccine that was offered. He said, I'm going to wait until kind of the higher grade of vaccine is offered. This is a guy who lived for many years in the Congolese diaspora in Belgium before going back home and becoming president. So we did bear in mind there's movement between these spaces, and the anxieties and tensions felt in one place. They are going to travel by WhatsApp, travel by social media. So yeah, I think transnationalism is significant there.
I don't know if anyone looked at the intersection between class and these communities. So I teach in an independent school. The majority of my students are of Indian heritage. So in any given classroom, I would expect 2/3 of my students to be Indian. A lot of those students, their parents are something in the city, or more likely consultants at consultant level in the NHS. So their experience of this is very, very different. I only teach boys, it's a boys' school. So what I've noticed pre-pandemic versus post-pandemic, so like gender attitudes have become hardened. I teach feminism as part of the A-level, and it's become a battle that it wasn't 4 years ago. So 4 years ago, I would have students go, yeah, it's really perspective changing. And now what I get is, but don't you agree that mostly women want to stay at home with their children? So their attitudes have completely shifted over the last 4 years. But their experience of this, I would certainly say my students wouldn't recognise any of those experiences. So when we said to them, you know, some communities were more likely to die during the pandemic, why do you think that is? They will all say, oh, because they're doctors, because they're consultants, because they're working in the NHS. And so their experience of this is much different, and the people they're speaking to is much different. And I was wondering if that had come through in any research when you were looking at those kind of intersections, or whether it was focusing on those who were left behind rather than those who felt that they were part of it. So most of my students, for example, would say that they felt protected by the state or restricted by the state because, I mean, they're 17 now, so they felt like they missed out, or, you know, they didn't see. And when I've asked them about race in public discourse and public communications, they don't see it at all. They'll say, no, that's not anymore. One of us is a prime minister, so it's fine. There's never an issue of race for us. And I wondered if that had come through, or if they wouldn't be the focus of the research.
Sorry, can I interject there? Because sorry, I'm a British Indian. I'm a very working class background. I don't work in the NHS. I care for elderly people. So not all of us are like that, and we don't have those attitudes. Just to quickly interject, I do think those kind of attitudes about women have been long standing in particular in the Indian community. So I wouldn't say that they've changed in the last few years. I would say that we do have in many South Asian communities, we do have a backward looking idea of what women can achieve and what and our role in society, whichever society that might be. So sorry about your experience there. That's not all of us. And just to say that although there are people of British Indian and Indian origin in the NHS workforce, there are people who aren't in the NHS workforce, but who I look after people that are elderly. It's something that we do. We have intergenerational living. We care for people. That's part of our culture. We don't think in those ways, and we're not quite blinkered, and we don't adhere to the government's idea of what we should be doing and what we shouldn't be doing. So just to say, there are lots of us with different types of attitudes. So
yeah, I think my students are quite unusual.
Thanks. Any particular response to either of those comments?
Well, we were certainly looking at low income households because the East End is predominantly working class community. And I absolutely agree with you, intersectionality, race, class, gender is important. And so if we widen out what we might see as the future on a macro level, then I think you can talk about healthcare system that widens out care to look at the individual, to look at a community sensitive or culturally appropriate approach. So that's healthcare in a much broader sense. So the communities perhaps that I've been looking at, then that would also include a racial trauma informed approach. Now the IRIS programme has been very, very successful with regard to domestic violence, where immediately you have a GP that is sensitive to what's going on here, the issues being presented, and then there is a different system in place, a care system that kind of fast tracks or is very much empowered to treat that person in a wider sense, knowing what they're going through, knowing how their health issues are related to what they're going through. So a racially, which is what FLIA advocates, racial trauma and health outcomes are very, very interlinked. So yeah, so I think that is something that could certainly be factored into the community that I studied, a racial trauma approach to healthcare.
Yes, all I'd say, kind of underlining what your pitch was for the panel as a whole, is around sort of ways in which ideas of diaspora help you to sort of explode those sort of essentialisms and appreciate how like the 5 fingers are not all the same size in the same way. I mean, our project was actually because we were trying to understand spectrum of COVID experiences and how was COVID experiences shaped by their social positioning. So we do look at intersections of class and racial identities and how you could, we have sort of middle class South Asian people, working class South Asian heritage, and that allows you to sort of see the ways in which things come together and separate in that sort of more intersectional way. And you know, I think it's highly complex. The way that we're analysing the data, we're scratching the surface of it. It's slightly it's overwhelmed, but we're sort of looking at the ways in which people register risk and sort of social risk. And something that comes out is that the ways in which racialized risk gets articulated is not constant. Some people have a very clear racialized analysis, and others is much more about occupational exposures. So that Pakistani woman whose husband is an Uber driver, who I talked to you about, when talking about risk, she reads it in terms of the fact that her husband is a taxi driver. But at the same time, that's not separable from the forces historically which have led 4 out of 10 Pakistani men to be working in taxi industry. In a similar way, you know, you've got people who sort of narrate really intense and hard-hitting experiences of racial discrimination during the pandemic, but still, when they're asked to articulate ideas about risk, pin it on genetics or, you know, biological predispositions, or even, you know, I don't know, that things are highly complex, and there's just so much that comes into the ways in which people understand and read risk.
And I think that I think that recognition of the complexity of these different lenses is quite a good place to draw a pause, because it's been quite an intense morning. Up to the end of the session now, so we're gonna have a little lunch break, but we're all still here.
But we'd love to hear what you wanted to say.
No, I just wanted to emphasize the issue of this class, but I think she raises a very important point about age, which is also very important. And I've also been, we're going to be listening to the young people. When listening to these stories about COVID, the voices of young people are conspicuously missing. I did a research in Tanzania and was asking young people their perceptions within the context of the COVID denial by their president, and their views were very different from everybody else. For example, they were saying they didn't have information when we talk about communication. So they were saying the reason Kenya has closed borders is because people are very mean, so they did not have information. So I think just to try also to get, you know, perspectives of young people, also which may be drawing from from different ways in which they perceive themselves. Also, you talk also about you know, trust and how they see their Britishness also, and you know, which may be very different from other people. So I think that lenses of what young people, I mean, their perspective is quite important going forward.
There's so one thing, if I'm allowed, in our in the so the COVID studies website, if you're interested in young people, there's like 4 different sister COVID sites, and there is one about, so there's 2 about long COVID. They were talking about what does it all imply for things going forward, and long COVID is an important part of the picture. So there's a whole resource on long COVID. There's a whole resource on young people's experiences of long COVID. So.
And we're all here, so I'm sure if you have any questions, lunch, you can come and talk more. So thanks so much for joining us.